So I'm Monty Mythen, Editor-in-Chief of Top Med Talk, bringing you Journal Club. Top Med Talk. On this Journal Club, we're going to look at a paper published recently in the journal Perioperative Medicine. You'll find the link in the show notes on topmedtalk.com. The paper's entitled Acute Kidney Injury in Postoperative Shock: Is Hyperoncotic Albumin Administration an Unrecognized Resuscitation Risk Factor? It's from Uday et al. It's from the Cleveland Clinic in the United States of America. It's a retrospective cohort study where they've included just over 11,500 perioperative patients with shock in a time window from 2009 to 2012. Shock was defined using fairly standard criteria with regards to the need for vasopressors to maintain an adequate blood pressure and/or an elevated lactate. They took out subsets from the 11,500 patients of 3,600 patients, where they carefully matched the patients using propensity score and exact matching on demographics, comorbidities and treatment variables, of which there's over 30 of those that they use. So they've worked really, really hard, and they show all the detail in the paper, to try and do this matching process to say, here we have two groups of 3,600 patients in each group where we can say they look as though they're similar. Now let's have a look at the effect of certain things. And they concentrated on the possible effect of the early administration of hyperoncotic albumin. So to be clear, this is hyperoncotic albumin, so as opposed to the normal 4 or 5% albumin that many of us use, this is often comes in smaller bottles and it's concentrated albumin, so 25%. And we'll come back to that in discussion. They had a preponderance of cardiac surgery patients. They then went through plenty of fancy statistics with proportional odds logistic regression, multivariable logistic regression, Cox proportional hazard regression, model measuring, etc., 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 looking at the association between hyperoncotic albumin and acute kidney injury. They also looked at hepatic injury, ICU days, and mortality. Now, why did they go after this subject area? Well, there's been an increased use, which we'll come back to in discussion, of albumin in recent years. People still believing that the administration of colloids as opposed to crystalloids may produce benefit in outcome as a result of raising albumin levels and raising colloid osmotic pressure. Now, there's been some concern, particularly with the use of hyperoncotic albumin. Not only is it expensive, and also you don't necessarily know what you're getting in the bottle because it's a blood donor product, effectively, and it comes in different guises from different manufacturers. But there's this recurring theme in the literature of what's been called nephrotoxicity, but actually it's a sort of hyperoncotic renal failure associated with hyperoncotic solutions. Now, we don't have time to go into the details of that. It's covered off in the paper, and there are some other excellent references there where you can read about the pathophysiology of that. But you can reproduce that in animal models, you can show what happens histologically, and it makes sense that by the kidney filtering hyperoncotic solutions, you start to mess with the fundamental processes within the kidney where it relies on oncotic gradients to allow water to move from one pipe to another, putting it very crudely. So there's a concern there that not only is it expensive, but the hyperoncotic solutions could cause harm. And indeed, that's what they found. In their 3,600 matched patients in shock with the preponderance of cardiac surgery, they found that hyperoncotic albumin-exposed patients showed a greater rise and risk of acute kidney injury compared to controls. And that was statistically significant. If you go down in the paper to one of the figures later on, where they highlight the difference between the twos, there's a difference in acute kidney injury stage 1, stage 2 and stage 3. Although stage 1 is the most common, there's a subtle difference there, and the incidence of AKI is 20.3% compared to 19.6% in the controls. That difference gets bigger as you get to stage 2 and stage 3. 2.9% compared to 2.5% for stage 2, and 4.4% compared to 3% for stage 3. Now, these magnitudes of differences, although they appear relatively small, are similar magnitudes of differences in what's badged as acute kidney injury to that sort of finished off hydroxyethyl starch. So I'm now going to bring in special guest, Professor Mike Grocott, who's the editor-in-chief of the journal Perioperative Medicine, to discuss a little bit about this paper, but also to reflect on some other literature in this area and where we think we stand on the whole colloid crystalloid albumin debate at the moment. So, Mike, are you there?
Monty, hi.
How are you, Mike?
I'm good. I'm just recovering from some obviously very severe man flu, but no, I'm doing fine.
And I believe you're at the Royal College of Anaesthetists today. Is that doing some of your duties there?
Well, I've just dropped in to use the fellows' room. I was down at the LSE earlier on, and the fellows' room was a convenient place to hang out to chat to you.
Right. Well, thanks for coming to talk to us about this today, Mike. So this has been a shared interest of ours for very many years. First of all, congratulations on publishing it in Perioperative Medicine. Can you tell us about the other editors-in-chief, current editors-in-chief of Perioperative Medicine? Who else is doing the job with you now?
Lee Fleischer from Penn is the other editor-in-chief, along with Cliff Coe, who is, as many of you will know, a surgeon who's recently joined us. So there's now 3 editors-in-chief and more of a spectrum across anaesthesia and surgery, and I think that's a big step forward.
And Perioperative Medicine, the journal, is the official journal of evidence-based perioperative medicine, which we're very proud with that affiliation. You can find the journal online. It's all open source. Is that right, Mike?
Everything is available full text, free online. So if you just put in Perioperative Medicine, it comes up first or second on a Google search. Go straight there. You can see all the papers, and you can download the full papers without any obstacle at all. So this,
I'm looking at the PDF, which I downloaded earlier on today. Everyone can do that. If they follow the links in the show notes, they can go in and get this paper out for themselves. And I think there's a number of reasons why that would be helpful. And not only is the discussion, I think, very well written, why wouldn't it be? It's in Perioperative Medicine, but it's very thorough from the point of view discussing the pros and cons of this sort of approach to data and what to make of it, strengths and weaknesses. But also there's an excellent list of references if you want to pick around, and I'm going to choose a couple of those in a second to draw out some of the context issues related to this. So, Mike, strengths and weaknesses of these sorts of reports, do they give us answers or questions?
Yeah, from my perspective, they give us questions. They can be really useful for highlighting the important questions. But you've always, in these big observational studies, got this issue of the risk of residual confounding, and as they acknowledge in this study, although it's a big data set, it's from a single centre. So with this in particular, that you wonder about generalisability. There may be something particular to the practice in this centre that has been part of the association that they've identified.
And I think they cover that off very well in the final conclusion where they say, given the retrospective nature of the study, we view our findings as preliminary and indicative of a need for prospective randomised studies to achieve greater validity and to identify the mechanisms for this apparent toxicity. So a very, very fair conclusion, I would suggest.
I think the very, very well-written paper, and that's no reflection on the paper. I think they highlight the strengths and weaknesses, as you say, very well.
Now, on the whole colloid crystalloid and the role of albumin debate, one thing I've noticed, this is an anecdote now, but I think it's backed up by sales data, is that as hydroxyethyl starch has fallen out of fashion, and colloids to a certain extent have fallen out of fashion in the intensive care units in particular, people have embraced albumin again. Is that happening in your neck of the woods?
It is. It's happening both in Southampton, what I see directly clinically, again, brackets anecdote, and it's also happening when you chat to people at meetings. It seems anecdotally a very general phenomenon that in the absence of or feeling nervous about using other colloids, albumin, I think most people, well, I think it seems a bit more natural for reasons that don't really necessarily make sense, and we've done very big studies that demonstrate it doesn't kill people. So if people do feel the need to reach for a colloid, I think they now commonly reach for either hyperoncotic or isooncotic albumin.
So now there's safety issues. You say we have had a large prospective randomised controlled trial under the title of Albios, which suggested at the end of it that although there was no benefit, there was no harm. Am I right in remembering it that way?
Correct, and of course in a different context, the SAFE study itself.
Going back to the original SAFE study, which again was albumin versus crystalloid. But in Albios was slightly different because it targeted an albumin level as well, didn't it?
That's correct, yeah.
So that's a reasonable conclusion, but in this paper they suggests that when you look at the result of Albios in particular, it sort of reinforces the idea that low albumin is a consequence of critical illness. It's not a driver of critical illness, because you can fix it and it doesn't make the outcomes any different. This hyperoncotic concern, because they say at the end about the mechanism of it, I thought the mechanism of hyperoncotic renal injury, by my reading, was pretty well described in the literature and backed up by animal models that suggest it's a real phenomenon. And I see quite a lot of it being given these days, again, for possibly similar reasons, about people going back to worrying about COP and low levels of albumin. Are you seeing hyperoncotic being used as well?
We are, and I think more commonly, for reasons that are not necessarily rational, but more commonly than isooncotic. So in clinical practice, I most frequently see what we have available, which is 20% albumin being used, even occasionally with a bit of frusemide, which again, one can question the physiological thinking behind that, but that is an approach that we see.
Now I had that beaten out of me. I had that beaten. That's strong words. I had that whole story sold to me as a child on critical care as a young doctor, and then there was another 15 years where I was that was almost beaten out of me by Andy Webb, for example, to say, "Hang on a second, this is all crazy. Stop doing that." Where do you stand on that?
I agree. I do. So I find myself falling for when crystalloids are not adequate. I do feel there's a place for colloid therapy on occasions, probably a lot less frequently than we used to use them, and typically I reach for albumin. Now I probably would prefer the isooncotic product, but from time to time I'll use the hyperoncotic product, and I have to say this study. In the context of the broader literature around it, probably will nudge me slightly away from that in the future.
Because one thing we're fairly certain about now is the idea that you raise the colloid oncotic pressure with, for example, hyperoncotic albumin, and that would suck water back into the blood vessels. I thought we pretty much knew now that was wrong. It doesn't work that way.
My understanding from the newer literature and the so-called revised Starling concepts around this is that that's not how it works at all. Appealing as it might be, sort of intuitively from the medical school physiology we get, there doesn't seem to be any evidence that it's actually true.
Yeah. So I know there's some controversy around that as well, and there's some literature from other quarters, not necessarily stuff that Tom Woodcock, who was a colleague of yours in Southampton, agrees with. But we took part in a round table earlier this year in Durham in the United States of America. And of the group that looked at total body water and distribution of body water, that seemed to be a firm conclusion. I'm just going to play a clip from that, Mike, to remind us. It's actually in conversation, and I'll put the show note, the clip link in the show notes at the end of this as well. I'm doing an interview after the sort of major round table with Manu Malbrain, extremely well known in the fluid world, with Tom Woodcock, who's credited with the sort of new Starling forces descriptions and papers related to that, and Henry Howe as a medical student. And here's the conclusion from Manu Malbrain on that point, on that very point.
What I learned during the meeting is that I used to give hyperoncotic solutions like hypertonic albumin 20 or 25%, and with the impression to attract fluids going back, reabsorption from the interstitium to the intravascular space. And I think that's a major issue, what we learned today, that the filtration may happen from the fluids, but the reabsorption needs to come from the lymphatics, or maybe from the different sizes of the buckets beyond the...
return of fluid, Manu, rather than reabsorption. Reabsorption is what doesn't happen. Yes.
So, Henry, do you want any clarity on this? I know you were in there for the detailed discussions, but what do you think are some of the key take-home points from that area?
So for me, I mean, we're taught that you have the filtration and the reabsorption, but I didn't know before Tom brought it to the table that actually this reabsorption just does not happen unless under particular circumstances. And for me, because of that pathway and the emphasis on the lymphatic way of getting back in, that's something that we really do need to bring into our clinical teaching and the way that we think about how we are treating with fluids, because it is the most important key role.
So there we go. That's certainly the conclusion from that. And I'm going to go back again, because I've been giving in a little bit too easily, perhaps recently, with people and saying, well, if they really want to give the hyperoncotic albumin, we don't think it's going to benefit the patient, but it's stressing the clinician who wants to give it, and it probably won't do any harm, so carry on. But I kind of might tip a little bit away from that again and say, well, hang on a second, there is a signal of possible harm here. Well, should we hold out for the large randomised controlled trials? What do you think, Mike?
I think I share that view. I mean, we've talked about the strengths and limitations of this paper. It's not a practice-changing piece.
No.
But as always, your clinical practice is nudged a little bit one way and a little bit another way by the different things you read along the way. And I think this probably will nudge me away, certainly from hyperoncotic albumin. I'm less nervous about iso-oncotic albumin, but I think I agree with you.
Yeah, because I think the way I'd frame it is, are you aware of this recent paper? Because if you still feel passionately about giving it, are you giving it in at least aware of that signal of possible harm, is the way I think I would frame it. I wouldn't, as you say, it's not it's practice changing, but I would throw that into the discussion for consideration. Can I just touch on two other papers, Mike, which are both cited here, because they bring back in this concept of where we are in the journey of illness. So context came to the forefront in the discussion of the bad news, the possible bad news related to hydroxyethyl starch and acute kidney injury. And in the ADKey meeting that followed the falling out of love with hydroxyethyl starch, a series of papers produced where context was brought to the forefront. In other words, we have to be very, very careful about taking data from the fully established critically ill patient and taking that learning into sepsis, early sepsis, and in particular, elective major surgery. Where are you on that at the moment, Mike?
So I agree with you. I think that the context is arguably everything. I mean, notwithstanding where you sit on the spectrum of, for example, belief in goal-directed fluid therapy, there does look to be a different biological signal from established critical illness through to acute injury. And I think that it's perfectly reasonable to assume that the same would be true in relation to which type of fluid you use. And I mean, we've talked about before the fact that in relation to hydroxyethyl starch, there's clearly a harm signal with sufficient dose. Although you can say that about a huge number of other drugs that we give that we don't get so stressed about in the critical care context. Whereas it's unclear with a modest dose if that's true in the perioperative care context, and that's not to reopen that argument. It's just a we don't have the literature, and b it simply may be a different set of biological processes where the consequences may be different from a particular intervention.
So to inform that debate, I sent you the links, Mike, to two other papers which are from the reference list contained within the perioperative medicine paper. There, two common names in both of them are Karthik Raghunathan, who's currently at Duke University Medical Center, and Andy Shaw. There are other authors in there as well, but that's the way you can look it up quickly on PubMed. I'll put the links into the show notes as well, so you can go straight to the two papers. Now, they're both two large observational studies, broadly similar in design to the first paper we've been discussing, this sort of idea of taking large data, propensity matching, and then seeing if you're looking for signals and associations between certain treatments and harms. So the first one we're going to take a quick look at is published in Anaesthesiology, the December 2015 edition, and it's called Association Between Initial Fluid Choice and Subsequent In-Hospital Mortality During the Resuscitation of Adults with Septic Shock. And Karthik, who we know reasonably well, Mike, is the first author on that. So please do look that up and have a quick look. They've looked at about 60,000+ patients admitted to 360 intensive care units in the United States of America, one of these very large data sets that they've managed to get access to. And they've done all that magic with the data and the matching and all those sorts of things. And their conclusions are, when compared to the administration of isotonic saline exclusively during resuscitation, the co-administration of balanced crystalloids is associated with lower in-hospital mortality and no difference in length of stay of cost per day. When colloids are co-administered, length of stay and cost per day are increased without improved survival. So, as we know, Andy Shaw et al. At Vanderbilt went on to do this single-centre cluster randomised trial and sort of reinforced the idea that that observation might turn out to be true, that balanced crystalloids seem to be a reasonable choice. So now this is the context question right here. This is resuscitation of adults with septic shock. So the cohort is very much not elective surgery. It's very much ICU based, and they definitely have septic shock. I take away from that that's a very reasonable conclusion, which has been reinforced by that cluster randomised trial, that right at the moment an isotonic balanced crystalloid solution like Hartmann solution or lactated ringers is a pretty sensible choice. Is that a fair comment?
Yeah, yes, I don't think we have absolute proof, but certainly on the balance of probabilities from a number of studies, I agree with you that the balanced solutions look like they perform better than the non-balanced sort of normal saline type solutions.
And in this context, they say that the colloids increased length of stay and cost in this large observational study. Now, we know we've got large prospective randomised controlled trials to inform that as well now, but it sort of sounds as though in that context, the colloids probably aren't a great choice.
So I agree with you, but I guess this, we can't know for sure, but I would say that we've had two large randomised controlled trials of colloids in critical illness, obviously not with exactly the same inclusion criteria, but related, so SAFE and CHEST. And as far as we can prove things with randomised controlled trials, we proved you couldn't kill more people with colloids. Yeah. So I would be cautious about a conclusion from, albeit a very large observational study, but an observational study nonetheless. I would be cautious about drawing too many conclusions. Maybe confusions is more appropriate, but conclusions from that, given what we know from the randomised control trial literature.
Okay, let me jump you now, because we've got to close in a second, to, and again, Karthik and Andy are both authors on this paper. The first author is I think it's pronounced Kingeter or Kingeter, Kingeter. It's in the Canadian Journal of Anaesthesia in July of this year, 2018. Again, I'll put the link in the show notes. This one's entitled Association Between Albumin Administration and Survival in Cardiac Surgery, a Retrospective Cohort Study. Now this is a different context. So this is 6,000 plus patients undergoing on-pump cardiac surgery. So we're assuming that apart from their heart issues, they're starting reasonably well, they're not septic, they're getting colloids or crystalloids. In this situation, they're looking at 5%, so isooncotic albumin, and comparing it with crystalloid. And they do this propensity matching thing again. They end up with a smaller cohort. They end up with 1,095 in each group. And the bottom line in this context is that the albumin patients seem to have a better outcome. That in this context, the use of 5% albumin solution was associated with significantly decreased odds of in-hospital mortality, death, and all-cause 30-day readmission rates when compared with crystalloids. So it seems as though this issue is still live. I mean, again, this is a question, not an answer. But in a different context, we're getting, from the same authors using similar methodologies, we're getting diametrically opposing conclusions. Help. Yeah,
I think a fascinating study. And in this case, I'm not aware of a perioperative study in cardiac or otherwise where albumin has been randomised, or at least a substantial perioperative study where albumin has been randomised against crystalloids. So it's not a question where I think we have a trump card from the literature involving randomised controlled trials. Very intriguing. It's also intriguing, though, to understand why, as with all these observational studies, why was it that some of the patients received albumin and some didn't?
Yes.
Now, intuitively, I would imagine that it would be the sicker patients that got albumin, because that might have nudged someone to thinking, oh, maybe a colloid of some sort would be helpful. But that obviously wouldn't account for this result. But there must be something different about them because they got a different treatment.
Well, remember, this is an on-pump study as well, Mike. So I'm guessing, I haven't read this. This is in the Canadian Journal, so it's behind a paywall. I haven't read the full paper. I will read the full paper. I'm hoping to get Andy Shaw online later to go into a greater deep dive into this paper. But I'm guessing that the albumin was also used as part of the bypass solution, because there's different camps with regards to colloid in your pump prime or non-colloid in your pump prime. And if you're colloid in your pump prime, you tend to also be a colloid user outside of just the pump prime. And some people believe that does some magic, glycocalyx protection and other drag effects and everything that goes with it. So there's some biological reasons why it might be helpful. Or it may be a surrogate. It might be a surrogate for just better centres, if you do, or different centres.
Yeah, I guess to be fair to this one, in comparison to the first study we were talking about, it's from the Cerner Health Facts database. Exactly. It is a multi-centre study, so it could simply be cultural differences between institutions.
Exactly. So we're worthy of further exploration. Well, we need to wrap there, Mike. Christmas plans? What are you at home?
As little as possible. At home, yes. How about you?
At home for only the second time in a very long time. Now, your kiddies are pretty young still, so I'm guessing Santa will be coming to your house fairly early on his trip around the world and dropping off lots of exciting presents. Is that part of the plan?
Yeah, no, Santa will, and he's actually already visited by email and video. So our daughter was extremely excited last night to have a video telegram from Santa.
Oh,
it's amazing what he can do these days.
Well done, Santa. I know Santa's a regular listener to Top Med Talk, so thanks for that, Santa.
To be fair, well done to my wife, but
and well done to Jenny. Well, have a very, very Merry Christmas, and for everyone listening, Merry Christmas and or Happy Holidays. I just hope you all have a great time. Mike Grocott, thanks a lot for helping us.
Thanks very much. Merry Christmas.
Top Med Talk.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com, and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.